All right, welcome everybody to Methods Hour. We're back in back-to-back weeks for our second presentation of the semester. We will see you again in 2 weeks, which is also the same Friday for folks in psychology as our graduate student recruitment weekend, but we'll still be here at the normal time, noon on that Friday. I believe it's February 18th. I'm not sure yet if that will be completely virtual or if it will be a hybrid presentation. So just pay attention to the announcements when they come out, or feel free to send me an email if you're curious. But focusing on today, I am so pleased to introduce Dr. Leigh Goetschius. She's a data scientist at the Hilltop Institute, which is part of the University of Maryland, Baltimore County. She's also a recent, and when I say recent, I mean like 2021 last year, graduate of our own Department of Psychology here at the University of Michigan. While she was here, she studied the impact of early adversity on mental health and development, particularly neurodevelopment, using a strength-based approach and big data models. She was also part of the developmental training grant on biocontextual development. Her work was published in great outlets like JAMA Network Open, Neuroimage, Developmental Cognitive Neuroscience. But since moving on, she's leveraged her skill set in big data to, well, extend it to even bigger data in applied analytics using, for example, novel machine learning approaches to predict avoidable hospital events, which she's going to share with us today. So please join me in welcoming Dr. Leigh Goetschius.
Thank you, Adrian. I am excited to be here. I am going to talk to you all today about a predictive model that my team at the Hilltop Institute has designed to predict, like Adrian said, avoidable hospital events. And this model is regularly used by primary care providers to influence care decisions and care management. So I'm going to give you a broader overview of the model itself, and then talk about what is involved in the production predictive analytics that really extend beyond just the model itself. But before I get into that, I figured I would talk, if I could change slides, there we go. I want to start just by talking briefly about the Hilltop Institute, because it's kind of a unique mix between an academic research institute and a health policy focused nonprofit. So broadly speaking, the Hilltop Institute works to advance the health and well-being of vulnerable populations through research and analytics. So we strive to be a resource for federal, state, and local policymakers and to contribute to the broader understanding of how to better serve people and communities, mostly through healthcare. We are technically a soft money institution, but are funded largely through a contract with the state of Maryland, and we partner with the Maryland Department of Health to conduct objective evidence-based research and analysis to inform the state health policy, particularly policies and programs related to the Medicaid and Medicare programs in Maryland. I also wanted to talk a little bit about my background at Michigan and sort of then how I got to Hilltop, or sort of how what I've done at Michigan, what I did at Michigan translates to what I'm doing now. So as Adrian said, I am very recently leaving I've graduated, I guess probably 9 or 10 months ago now. But while I was at Michigan, I was in the developmental area of psychology. Chris Monk was my primary advisor, but also through things like the developmental training grant and just the great opportunities in Michigan, I got to work with Bonnie McLeod and Adrian and Luke Hyde and many other awesome mentors. Also, as Adrian said, my work was focused a lot on early adversity and socio-emotional development. I looked at the brain and behavior using things like MRI and survey data, and what I thought was big data then, but actually I feel like it's teeny tiny data compared to what we're working with now. I really, while I was at Michigan, tried to take advantage of the awesome statistical methods and data science resources that are there. So I did the data science certificate and was also a 3-time member of the Methods Hour course. You know, it's no Dominic, but, you know, I feel like it's respectable. So since starting at the Hilltop Institute 9 months ago now, I guess, I am part of the analytics and research team. There are 4 of us. I am officially titled a data scientist, but it's sort of a data scientist policy analyst. research scientists, sort of all piled into one. Our team focuses a lot on production predictive analytics, especially the model that I'll talk to you all about today. We design and code and evaluate these predictive models, working mostly with Medicare and Medicaid data, but also some other sources. In terms of outlets for the research, we write reports for the Maryland Department of Health, but we are also working on extending into more like peer-reviewed journal publications. So trying to keep our footprint not only sort of in reports for government agencies or our funders, but also in sort of the more peer review space to show everybody the really cool, exciting work that we're doing. We also collaborate with people at Johns Hopkins and the University of Maryland School of Medicine to work on grant applications. We just submitted one this week to the NIH for a firearm violence predictive model. And we're working on one for an Alzheimer's related predictive model. So lots of really cool, interesting work that we get to work on. So if anybody is interested, I'm happy to talk about how I found my job at Hilltop and sort of what the day-to-day job looks like. So my email is at the end of this presentation. So feel free to email me and I can talk about it because it's sort of like I said, an interesting mix between academic research and non-academic research at Hilltop. So I like it at least. Okay. So like I said, today I'll start with sort of a general overview of what we do in terms of production predictive analytics at Hilltop, and then talk about a specific model that sort of serves as the basis for our sort of preventive analytics framework. So at Hilltop, we answer questions for government agencies, foundations, nonprofits, and we do this using many approaches, including production predictive analytics. So we don't exclusively do that, but it's sort of one of our focuses, and it's my team's focus. We have access to a lot of state health data through our contract with the Maryland Department of Health, including Maryland Medicare and Medicaid administrative claims data, which is what we use for the model that I'll talk to you about today. We get updated versions of these claims each month, which is essentially real-time updates if you're thinking of administrative claims. It's pretty much as fast as you can get, which is means that we have a really rich set of healthcare data for individuals who are covered by Medicare and Medicaid in Maryland. We work with programs within the Maryland Department of Health to design and build and evaluate predictive models that are related to multiple different health outcomes. And to do this, we often harmonize data or link claims, like harmonize or link these claims with data from other data sets, including quality of care assessments, cost reports, and publicly available data sources that index social and environmental characteristics. We design predictive models for these different health outcomes that are transparent and actionable, and we try to use a combination of theory-driven and data-driven methods to make sure that the output from these models that we make available to our clients are informative and understandable, so they can really help guide and inform healthcare policy decisions and or clinical practice, depending on who's using the output. A large portion, like I've said, of our predictive analytics work is done in partnership with the Maryland Department of Health. And the main goal is to help improve quality of care for Medicare and Medicaid beneficiaries, while also keeping the cost of care manageable. So a core philosophy, or the core philosophy that really makes up this goal is made up of 3 parts. So first is the idea that people and payers should not be burdened with unnecessary encounters with the healthcare system. And one way to do that is to build up and support advanced primary care services. The second part of this philosophy is that advanced primary care is the most effective for the largest number of patients when care coordinators can focus their resources and effort towards individuals with the highest risk for poor health outcomes that can be addressed using primary care. And so one way to do that is statistical triage, or using predictive analytics to help efficiently identify high-risk patients. And the last and third component of our philosophy is that the appropriate method for statistical triage is event risk and not actuarial risk, or the cost of like how much care costs. Research has shown that models predicting risk for utilization events tend to be less biased than cost of care models because how much you spend on healthcare for a person doesn't always equate to healthcare need or even really health outcomes. And we focus a lot on avoidable hospital events because they, by definition, are the most likely to be prevented using care coordination efforts in primary care settings. And so really, to sort of delve in deeper to these avoidable hospitalization events, I thought I'd talk about actually how they're defined because I had no idea that that was really even a thing before I started reading about this model for my job interview. So there are many different reasons for a person to need inpatient hospital care or care at the ED at the emergency department that are really the primary care providers can't really do anything about. But there are a subset of causes or diagnoses that have been determined to be either well managed or prevented by timely quality primary care. So theoretically, a patient shouldn't need to go to the hospital or emergency department for these different conditions or causes if they receive regular quality primary care. The Agency for Healthcare Research and Quality, AHRQ, has defined this list of conditions. They regularly update it, and it's standardized across the United States. And avoidable hospitalizations generally are often an index for quality of preventive healthcare, both at like the state level and at individual provider levels. So it covers a lot of different, you can see here from the list on screen, lots of different conditions. So we end up with a pretty heterogeneous set of risk factors. Any questions or clarification needs thus far? No? Okay. So back to our predictive analytics. So our main predictive analytic tool is the Hilltop Preventing Avoidable Hospitalizations or Preage model. And this serves as a basis for our broader preventive predictive approach for now multiple different outcomes, which I'll talk a little bit later. But it's based on the premise that primary care providers and practices have a finite amount of time and care management resources. And so the problem really becomes how to direct or target these resources towards patients with healthcare needs that are most likely to benefit from these primary care services. So who can they help the most? Like who is in the most need of help and can be helped the most. So the Preage model estimates each individual patient's risk for avoidable hospitalizations. And then that allows us to give primary care providers a ranked list so that they can prioritize their care coordination efforts. So now they can start their outreach efforts with the patient who has the highest risk, who they are most likely to help, and work their way down from there. So conceptually, we predict avoidable hospitalizations and ED visits using risk factors from these 5 categories. The first is biologic and diagnostic, which covers diagnoses for conditions like high blood pressure, diabetes, and lots of other conditions, but covers those types of risk factors. The second category is healthcare utilization. So that covers previous hospitalizations, previous emergency department visits, primary care visits, specialist visits, really any interaction with the healthcare system at all, nursing homes, everything. We have pharmacy risk factors, which index prescriptions that the patient has received, and it also indexes vaccinations like flu vaccine, pneumonia vaccine, those kind of things. We have demographic risk factors like sex, race, ethnicity, disability status, and dual eligibility for Medicaid, especially for our Medicare population, which is like a proxy for low income. And the last category is social drivers or determinants of health, which index the physical and social environment where people live, because that also, as we know, affects health outcomes through mechanisms like access to resources, access like food and healthcare, exposure to pollutants, and also just sort of the general broader neighborhood environment. So our model tries to cover a very broad set of risk factors. In practice, these categories of risk factors end up being about 144 risk factors that are created based on an individual's Medicare or Medicaid claims history. That includes the demographic variables as well as risk factors related to diagnoses, prescriptions, procedure history, and prior healthcare utilization. And then we tack on around 37 plus or minus, depending on whether we've added anything, risk factors that are created using publicly available data sets like the American Community Survey or the Neighborhood Atlas, this information from CMS about like provider locations. We use IRS income tax data, lots of publicly available data sets. And we match risk factors created from these with the administrative claims data using either the patient's zip code or their census tract, depending on the model. So we actually recently developed an automated procedure to geocode each individual patient's address so we can get down to their block group, which has been a really cool and exciting development for this model. So we pitched this, almost 200 risk factors based on a comprehensive review of the literature related to avoidable hospitalizations, and also using feedback from different stakeholders, including both policymakers and providers, about what information will be most useful for them to know in order to either make policy-related decisions or things that would be helpful for providers to know as part of their normal practice, and things that they could really leverage and use in their general, their clinical workflows. We base the avoidable hospital event outcome and, when possible, the risk factors on standardized coding specifications that are available through places like the CMS's Chronic Condition Data Warehouse. And this, we think, helps make the model more transparent because people know how we're defining things and other people agree that that's a good way to define them. And it makes it replicable so that if people want to be able to create their own versions of this model, it's not using some sort of proprietary set of algorithms. It's using something that's more standardized. So we estimate this model for two populations right now. The first is Medicare beneficiaries who are affiliated with a Maryland primary care program. And so just as a reminder, because I feel like for me, prior to working at Hilltop, I always had to slightly think about which one was Medicare and which one was Medicaid, who covers what. So people generally become eligible for Medicare when they turn 65 years and older. So the average age of this population in Maryland, at least, ends up being around 73. And the Maryland primary care program is a subset of around about 400,000 patients from the full Maryland Medicaid population, which is about 1 million patients. And so Hilltop started making the risk factors for MDPCP back in October of 2019, and we've been making them really every month since. The second population are Medicaid beneficiaries who are enrolled in the Maryland Health Choice Program. So as also a slight reminder in general, Medicaid is available for low-income children and adults and people with disabilities. So the average age is a much younger 24 years compared to the Medicare program, so very broad age range of people. And so Health Choice is Maryland's managed care program for Medicaid, which is a whole other thing that we do not need to get into, but essentially it covers, or most people enrolled in Maryland Medicaid are enrolled via this Health Choice program. So it covers around 1.4 million Medicaid beneficiaries in Maryland, and that's, I think the total number is 1.5 million. So we cover the vast majority of Medicaid recipients in Maryland. And we started making these risk scores much more recently, just about in mid-2021. So actually, when we calculated it all out recently, we ended up making these risk scores for close to 2 million people. And given that Maryland has only about 6 million people, we're making risk scores for a decent chunk of the Maryland population, which is kind of humbling and mind-blowing statistic, at least for me. So as a note, both the Maryland Primary Care Program and Maryland Health Choice have financial incentives for providers to reduce unnecessary and avoidable healthcare utilization, which is why they really find the Preage model useful and have helped to make sure and emphasize like the use of it by the providers who are also affiliated with these programs. So the data that goes into the Preage model is structured in a person-month format. So that means that each person has a value for each risk factor each month, which makes for a very large set of data files and also very long-running scripts. Anyways, that's neither here nor there. We use a discrete time survival model to predict each individual's risk for an avoidable hospital event within the next month. So everybody gets a risk score that will be like adjusted for each month, if that makes sense. This is the general formula for the model that we use. I'm not really going to get into it because I don't think I would really do our team's statistician really any justice, but it's on here in case you're interested. And I'm happy to talk more about it or direct you to our team statistician if you have more specific math questions. So we use that statistical model and we train this. So we train the model on 35 months of data. So it's broken up into 80% training, 20% testing. Is pretty typical for machine learning models. And by doing this, we evaluate the subset of the 175, 200 risk factors that are salient for avoidable hospital events. And then we also calculate or estimate the scoring coefficients or the beta weights for each of these salient risk factors. We create the actual risk scores and what we call the reasons for risk, which accompany the risk scores. And I'll talk about those a little bit more shortly as well. But we create these risk scores and reasons for risk using 1 month of data in our sort of scoring set. So during this process, we essentially multiply each individual patient's risk factors that are created based on that month of data by the scoring coefficients that are created during our training model. And we sum the risk scores times the coefficients to get the total risk score. And then we can also rank the contributions to the risk score by each of the different risk factors so that we can get each individual patient's reasons for risk and so that they can be different across different people. The production version of this model is estimated using SAS, but we also run a validation version of the model, which is essentially like a shadow code that reproduces the production model. And we do that using Stata to make sure that the scores that we're creating aren't based on any single statistical software or any decisions related to the SAS code that would potentially change scores. And it also just serves as an additional quality check to make sure that nothing is incorrectly coded because we will have had to do it twice. So when we're evaluating the predictive performance of the Preage model, we look at multiple metrics. So the first is pretty standard. It's the predictive discrimination using metrics like the C statistic, which basically says shows how well your model discriminates between people who do and do not have avoidable hospitalization events. But because these scores are really intended to guide care management practice and because there are finite time and resources, we really care about whether the model actually assigns higher risk scores to people who have a higher likelihood of avoidable events. So the people with higher risk scores actually are having higher risk. So we measure this using things like the Gini index, which tells you about the statistical dispersion of events, like on the plot here. it shows, the cumulative fraction of avoidable hospitalization events on the Y there. And on the X shows you the risk. So you have on the Y-axis, you have the fraction of the total avoidable hospital events for your sample. And then on the X is the ordered risk percentile. So where, if the person is in the top 1% of risk, how many avoidable events hospital events do they actually have? So we focus a lot on things like the percentage of avoidable hospital events that are incurred by, our top 10% riskiest patients. So here, it's the top 10% of patients are accounting for 48% of the avoidable hospitalization events for the Medicare sample, and about 55% in the Medicaid sample. Let's see. And so we hope that that top 10% is a metric that we really is a cutoff metric for us, mostly because the care management people in the primary care practices say that they can really only reach about 10% of their patients each month. So we really want to make sure we're getting, we're giving them a good list of the riskiest people. And last, because we deploy these scores each month, we look at the stability of these scores, so like their correlation across months. And so we don't want the scores, jumping up and down every month, or else that would be very confusing. And so we built these claims-based risk factors so that they index about 6 to 12 months of medical history that helps make them relatively stable. So if you see here in the Medicare model, they're correlated month to month at around 0.96 and about 0.94 for the 0.95 for the Medicaid sample. And so hopefully the things that are changing are then, whether the patient is getting a new diagnosis or a new procedure, and not just, changing as a function of the model. We've really worked to make the output of the Preage model actionable and useful for providers. So stakeholder feedback during the model development process told us, or underscored, that providers not only need to know that a patient is risky or how risky a patient is, but also why that person is risky, or what is driving their risk score. So for each patient, like I said, we create that risk score and then the ranked order list of their specific reasons for risk. Like you can see on here, you can have a higher risk score and different reasons, like prior hospitalization, or maybe you have a provider administered drug, and for that reason you're a higher risk. And so providers and care management organizations can look at these reasons for risk and say, you're risky and this is why you're risky, so we can hopefully do X, Y, and Z to help. There are usually a lot more than 3 reasons for risk that accompany each patient score, but just for the purposes of illustration. And so if we weren't deploying these risk scores, this would probably be the end of the project. We'd probably write a paper talking about the common reasons for risk, or talking about the change in risk scores over time. But we'd probably already be thinking about, what to do for our next project, or sort of how does this contribute to what we would be doing in our next grant application or something. But because they are deployed for use in clinical practice, we have still much more to do. We worked with different vendors to develop a dashboard that's built into platforms that providers are already using, rather than a standalone platform. And through this platform, they can access the model outputs of these risk scores and reasons for risk. And each month, a decent portion of our time goes to making sure that the data gets from our servers to this place where the providers can access and use it. So we designed the Preage model with the intention that these risk scores and reasons for risk would be combined with providers' clinical expertise and personal knowledge of the patients to help prioritize care coordination efforts and inform intervention selection by showing, which risk factors are driving the risk scores. And the prioritizing of care coordination efforts is very important because, like I said, they're really only the primary care practices can really only reach about 10% of their patients each month to really try and specifically intervene or like provide extra support. And so we don't like the Preage model doesn't suggest potential interventions. We haven't combined it with a clinical decision support system or something like that that says these are the reasons for risk, here are good interventions, because we feel like, at least for this, that decision is best left to the clinicians, because the different interventions is going to be such a broad set given the broad set of conditions that go into avoidable hospital events. But the reasons for risk seem to provide a decent starting place for where interventions can be directed. And so these care management interventions are often things like medication reconciliation, patient education about their, their specific condition, or, what kind of resources are available, like what sort of like social community-based resources are available to help with care, scheduling assistance to make sure that they're, for example, for diabetes care, that they're coming in regularly and things are, they're appropriately managing their chronic conditions. And so it's not necessarily just like new medications or procedures as interventions. The interventions are very broad. And they're actually, the Maryland Primary Care Program at least is starting to expand what they consider advanced primary care by starting payments that address social needs of their patients, like non-medical needs, I guess. So they're calling them health equity advancement resource transportation or transformation or HART payments. And these are intended to be used to, like I said, address the more non-medical needs of under-resourced Medicare beneficiaries. So it can be used for things like food, housing and transportation needs. It seems to be a lot of connecting Medicare patients with different, like enrolling them in different existing social programs to leverage great tools that are already available, but that can be harder to access or sort of get into. So very broad set of interventions, which I think is really cool. But a sort of last critical part of deploying the Preage model has been making sure that providers actually trust the model and the risk scores and how they're created, because if they don't trust them, they won't use them. And if they don't use them, then we won't get paid to make them anymore, and that would not be great. So that involves creating and maintaining really in-depth, transparent documentation about what goes into the model, why we pick different risk scores, how the risk scores are created, lots of information. The most recent version of our Preage code book is actually 83 pages long. I'm still working on finishing it. And we've also worked with the Maryland Department of Health to hold training sessions for providers and care managers to make sure they understand the purpose of the risk scores, the metrics, or understand all of it. It's been quite the investment in terms of time, but definitely worth it, because I think the most recent statistics are that I think like 96% of the care transformation organizations access these scores, and qualitatively people report really finding them helpful. So the documentation we think is definitely worth it. So in terms of what providers actually see, obviously every patient's risk score can't be sent out to every single provider that's enrolled in the program, because that would be definitely a violation of patient privacy. So what each provider gets is a list of their patients, and like that list is ranked based on the relative risk within their practice. So someone can have the third highest risk score of the whole population, but will be ranked as the riskiest person within that specific practice. There are pros and cons, I think, of providing relative risk estimates, but it does accomplish our goal of helping providers to know who in their specific set of patients is at highest risk and why. So here's what they would see when they log into that platform where the scores are kept. They could see the patient, which would be a name rather than a number. They could see their specific likelihood of avoidable hospital events, and then it's color-coded based on the percentile of risk. And then you can click on each patient and sort of hone in on that specific patient and their reasons for risk and sort of which categories are driving it, so they can get a nice comprehensive look at each patient's risk and reasons. And, you know, at the end of that, we just do it again. So this is sort of our monthly process for making these scores for both the Medicare and the Medicaid sample. You know, we download the data, we do our quality checks to make sure that everything, you know, there isn't some incomplete claims data or anything like that. We pre-process the data to separate it by time, define our event outcomes, create all of our different risk factors. Then we train and score the model, deploy the output to providers, and then hopefully inform and guide the distribution of care resources. And then we also regularly solicit stakeholder feedback and monitor predictive performance of both of the models, just to make sure that there are not things that need to be changed, because it's sort of a iterative, regularly updated process. Yeah, and so that's sort of the end of the Preage model framework. We've been building on it a lot. We now have a model for COVID-19 hospitalizations to help identify people in the Medicaid population who are at highest risk of COVID-19 hospitalization. We're now working on creating a model for opioid overdose in Medicare and Medicaid. Like I said, we just submitted an R01 for firearm injury prevention, also one that we're about to submit for predicting hospitalizations and long-term care use in Alzheimer's patients. And we're creating a new one soon for complications of type 2 diabetes, as well as need for hospice care. So sort of building up our predictive analytics suite. And so yes, that is what I have in terms of the presentations. I figured we could have a discussion now about whatever you all want to talk about, but these are the questions I had come up with before. So.
Thanks so much, Leigh. Really interesting work. We can tackle these questions, but maybe first we'll just open it up for general kind of questions or comments about what you presented.
Yeah,
see
for
if
sure.
there's anything on that front, and then we can dive into these questions. So yeah, folks, feel free to unmute yourself and ask Leigh a question, raise your hand, use the chat, whatever is most comfortable for you.
I'm unmuting.
Hi, Daniel.
Hey, there I am. Okay, so great talk, Leigh. Thank you so much, and it's really exciting to see what you're doing now. And I just had a question, a couple of questions. So what's really interesting to me, and perhaps is two things. One is, it seems like you're applying many of your research skills kind of in the real world, right? Instead of as an academic. And I just wanted to get your perspective on kind of how that feels. Like, do you miss the academic part, or do you prefer the real world part? As an academic, I often feel like I'm not sure how anything I do relates to the real world directly. It's a little bit more like the accumulation of knowledge that might someday get applied, whereas you're really in an applied position. So I'm just curious how that feels. I guess the second question was what you raised earlier, kind of like what your day-to-day experience at going to work is like, and how that compares maybe to what it was like as a grad student or something like that.
Yeah. So I guess I enjoy the more applied, I guess, side of it, because I think it's exciting that the models that we are creating actually have a direct impact on life, but that's also kind of scary. I feel like I think like one of the discussion topics I raised was that, you know, we're actually hopefully guiding, you know, how resources are distributed to different patients. So it sort of comes with the responsibility of making sure that we're doing the best we can to create like unbiased models that are helping people and not, you know, worsening existing healthcare disparities or anything like that. So I feel like it's exciting, but can also be a little bit overwhelming when you think about the responsibility that comes with what actually people applying what you're doing. But I feel like my day-to-day research or like day-to-day life doesn't look that much different, I feel like, than when I was a graduate student, because I'm not teaching, which I also wasn't by the end of graduate school because I was on the developmental training grant. So I feel like I just spend my day reading, writing grant applications, writing journal articles, and analyzing data. So it's actually very similar, but just with a different outcome, I suppose.
I see. And so you're writing journal articles similarly to how you would in graduate school? I mean, or I guess.
Yeah, I mean, I'm working on one now. I think, like I said, we've just developed that procedure to like automatically geocode people's addresses. So now we can use census tract level environmental risk factors. So I'm writing a paper now that's comparing, like, if you're using zip code level risk factors versus census tract, does that actually help you? Is it worth taking the time to geocode all of these addresses, or can you just use zip code? The answer, if you're wanting to know, at least in our experience, was that it's similar predictive power, but it does definitely change model interpretation by using the more granular risk factors, and decreases the weight that's attributed to things like race in our proxy for lower income, and hopefully distributes that to more actionable risk factors. So in case you're wondering, but so writing journal articles in a similar way.
Wow. And I forgive me if I'm going on too long, but did you already say, I came about 5 minutes late, so just disregard this if you already said, but what guided your choice about whether you would continue in academia or move to a non-academic position? I can't remember. I may have missed that.
No, I didn't say it. But I feel like it was a lot of what you like I wanted to do something that was a little bit more applied and sort of had more of an effect on actual people. Because I think, but definitely in graduate school is contributing to the broader knowledge, which I think is great. And I know I did some really important and impactful work, but just less directly so.
Cool. Thank you so much. That's really interesting.
Really exciting. Hi, Leigh. It's good seeing you again. Thank you so much for sharing this. This is really cool. Like getting insight into what you're doing right now. And it sounds like it's really important work that you're doing. I'm wondering if there are plans to apply these models in sort of other types of hospitalizations. I'm thinking like psychiatric or like ER, or even expanding it to other states.
Yeah, so I think my boss's goal, I feel like whenever he talks about these predictive models, is like, we're not just creating a predictive model, we're creating a framework that can be applied in other states, and for not just public insurance options, but all payer options. So we're part of like a state university partnership coalition. So we partner with the state of Maryland Department of Health, and then there are other universities in different states that also partner with their state departments of health, or like their the work with the Medicaid programs within their states. So we sort of have this network of state university partnerships where we can look at similar questions, and I think a goal would be to look at how this functions in other states. Maryland is a little bit of I think a unique state, because they really do prioritize healthcare decisions a lot, and they put a lot of money towards Medicare and Medicaid and healthcare generally. So looking at this model in different states that have different priorities, I think will be interesting. We could, I think, even breaking it down by Medicaid expansion status, so whether or not they've in a state decided to expand Medicaid coverage to childless adults at a certain income level, which is not universal. So I think there are plans to do that, but the state of Maryland is what pays our contract.
Yeah, thanks, Leigh. I just also want to draw attention to Pam Davis-Keene's comment in the chat. She says, so cool to hear about the immediate impact you're having, amazingly. And I think we all couldn't agree more. And at the risk of turning this academic, I have a question for you. I'd love to hear your thoughts. one thing about kind of predictive versus maybe descriptive modeling, that in predictive modeling, you're interested in predicting an outcome. And it doesn't really matter how that outcome is predicted. Just if you do a good job, classifying or capturing risk, if the model does a good job, that's the proof. That's the proof for its utility. And that makes good sense. But from like a psychological perspective, then when folks want to say, and I think there's a little bit of this in the article you shared and is posted on our website, well, why? Or where does that risk come from? Or what's the mechanism? Or you get a little bit at who's riskiest, but again, why? That kind of descriptive, the nature underlying the model, I guess. And not that these models should do that, but to what extent do you think about that? Or is that in a side project of this, or is the focus really on predictive modeling and for good reason to be efficient and predict outcomes? But do you ever find yourself like wondering, okay, why, where did it come from, who?
All the time, because I feel like I also think we have, so, each month when we do this, I help more with the validation model than the production model. So I feel like we, run this every month, and I'm looking at these, risk scores and the different coefficients of different risk factors. Why would this one be this? Or like, I wonder what causes this different combination of risk factors. So what if we started doing the interaction between, having asthma and then like air pollution in there? And I feel like I've learned since getting to Hilltop that there are, it's like, okay and exciting to have these thoughts, but then actually sort of digging into it and figuring all of that out would definitely be more towards like satiating my own curiosity than something that would affect the model too much. So I feel like I don't do that as much as I want to, but it is, I think I think you could write just a ton of interesting papers about this. And so we are working on it. Actually, we're getting a graduate research assistant this summer that will hopefully help us write more of these papers and dig more into this.
Fun.
I think about that all the time.
Yeah, that's really interesting. Phoebe raised her hand.
Yes, I'm Phoebe Ellsworth, and I haven't met you, but I was curious that what about people it seems to me that many of the people who get a lot of avoidable care are people who don't have primary care physicians, the people who just go to the emergency room and don't have health insurance or a doctor. So I don't know how big a problem that is in Maryland, but could you say a little bit about that?
Yeah, so I think that's definitely like a very important point. And I think one of the good things about Medicaid expansion that came with the Affordable Care Act is that there are fewer uninsured people because the range of people that qualify for Medicaid is so much broader. Because I think a big push in people who are enrolled in Medicaid in Maryland, as well as the people enrolled in the Maryland primary care program, is to help people get into and established in primary care because it does seem to be so protective and helpful in terms of long-term health outcomes. So I think it's a problem. There are people who will go to the emergency department for strep throat or something like that because they don't have a primary care doctor where they could go through and get treatment for that. And I think that's one of the things that these models are designed to reduce, and sort of that paired with the primary care, advanced primary care incentivized programs to sort of be able to better predict who needs help and also help emphasize the importance of primary care. But definitely a problem if you don't have health insurance, for sure.
Thanks.
Any other questions for Leigh?
I have a question. So this is probably just related again to sort of differences in employment, but in comparison to, well, I'm thinking about like a lot of graduate students might do a postdoc or something like that afterwards, and then have kind of stress related to will they get a job or this sort of thing. And I wonder if you can speak at all to things like work-life balance or stress levels, or like, do you think they're lower now? Do you worry that you're not going to have a job in 2 years? Or is it more like, hey, you have a job, a kind of path forward, you're not starving, you actually have a work-life balance? Like, what's that whole thing like apart from, you know, your exact day to day?
Yeah, so definitely more the latter, because I think if you don't already know, and I think you do, Daniel, that I have a 2.5-year-old. So my personal life is my family life is very important to me. And so I really wanted a job where I could work normal hours and not have to be, working on the weekends all the time. So I couldn't spend time with my son because he's already at daycare all day. And I also have a partner who's in an academic job. So sort of moving around is I think more difficult. I'm sure as a lot of people here know. So actually the nice thing is my job is based in Baltimore County, and I go every once in a while, but I work mostly remotely from Virginia. So I live about like 2.5 hours away from the office and go up. I think I've gone up like 4 times since I started working there. And so I can work from my house, which is great. And my boss is super supportive of me doing this. So that's really great. So I think that I enjoyed that I have some stability, and like I said, I think at the beginning, even though it's technically like a soft money research institute, the contract that we have with the Maryland Department of Health has kept them continuously funded for the past like 25 years or so. So we don't, it's more of like an ISR type funded, where you're not as stressed about your institute losing funding, or I don't have to bring in, grants or my own specific contract to have a job, which is nice.
Thank you. That's great.
Yeah, thanks so much for sharing that, Leigh.
Yeah,
I think
thank you for
the context in which science happens is almost maybe as or more important even than the science itself. So really appreciate hearing about your experiences.
Yeah, thank you. Thank you for having me. This was fun. It's my first presentation officially talking about this predictive model. So this was a good experience for me also. So
yeah,
thank you.
Really wonderful. We really appreciate it. Thank you so much. You're welcome back anytime. Just let us know. I'd love to hear an update on where this goes, but really appreciate your time and really awesome work.
Yeah, thank you. Bye.